Dr. Priyadarshini, one of the mentors with StudyMRCOG, and today we are going to discuss on physiology. Acid-base balance, we have a question. The nurse is caring for a patient who has been comatose for 1 week. Analysis of the arterial blood gave the following values. PCO2 is 16, bicarbonate is 5 and pH is 7.1. We have to know how we are going to approach such kind of questions. The normal value of pH is 7.35 to 7.45 and PCO2 is 35 to 45 and bicarbonate is 22 to 26. The step 1 is going to assessment of pH. We are going to see whether it is acidotic or alkalotic. In acidosis, the value of pH is reduces to less than 7.35 and alkalosis it goes more than 7.45. Step 2 is to look at the partial pressure of carbon dioxide, and if both the pH and PCO2 are in the same direction, it is metabolic, and opposite direction it is respiratory. In metabolic, the bicarbonate ions are affected, so pH, PCO2 and bicarbonate are going to go in the same direction. So in metabolic acidosis, we find the pH is reducing. The primary disturbance is with bicarbonate. The value is also low. The secondary response is from the respiratory system. So PCO2 is also reducing. Alkalosis is just the opposite. In metabolic alkalosis, pH increases. So does your bicarbonate level, which is the primary disturbance. The secondary response, we find that the PCO2 also increases. Respiratory acidosis, we find the pH is low, the primary disturbance being PCO2 high, and the secondary response is from the kidneys, so the bicarbonate increases for compensation. In respiratory alkalosis, the pH increases, the primary disturbance, because it's respiratory, will be in the opposite direction, so the PCO2 is reduced, and the secondary response is by the kidneys. We find the bicarbonate level also reducing. So this is in a nutshell about acid-base disturbance and how the compensation mechanism come in action. As I told, for metabolic conditions, pH is low, so is PCO2 and bicarbonate. The compensation for metabolic is from the respiratory system, which is going to be an immediate compensation. If you take example of respiratory acidosis, we find the pH less and the PCO2 both are in opposite direction, and the compensation is by the kidneys, which is usually a delayed response. So an easy mnemonic to remember is ROME. R is for respiratory in opposite direction and M is for metabolic in equal direction. So this helps us to solve these kind of questions easily. Coming to the male and female reproductive system, we need have some important questions to be discussed. They are the sequence of structures which are penetrated by the sperm, mostly about the hormones which are seen in the menstrual cycle and the time frames, and a little bit about spermatogenesis, oogenesis and the structures. Coming to spermatogenesis and oogenesis, this is the formation of sperms and the eggs from their respective primordial cells. Oogenesis, we have the primary germ cell, the oogonium, which is diploid. This gets converted into the primary oocyte when it undergoes the mitotic division. The primary oocyte gets arrested in the 3rd prenatal month, and then at puberty, the primary oocyte will undergo the first meiotic division to become the secondary oocyte and release of the first polar body. This is at the time of ovulation. After that, if fertilization takes place, the second meiotic division is completed, leading to formation of ovum, and the second polar body is released. Coming to spermatogenesis, we have the spermatogonium, which is diploid in number, undergoes mitosis to become the primary spermatocyte, which is again diploid in number, and then comes the meiosis. In meiosis, we see the diploid number getting converted into haploid. So primary spermatocytes get converted into secondary spermatocytes, which are N in number. Secondary spermatocytes again undergoes meiosis 2 to form 2 more daughter spermatids. These daughter spermatids will undergo differentiation, which is called as spermiogenesis, to form the sperm. So from one spermatogonium, we have 4 sperms being formed. Another important concept to be remembered is about the Graafian follicle and the structure, which is very commonly asked in exams. The Graafian follicle we have, it's also called as the antral follicle just before ovulation, and we see the size of almost 18 to 20 millimeters. The externalmost layer is the theca externa, followed by the theca interna and the basement membrane, which gets surrounded by the granulosa cell. We have the follicular cavity, which is filled by the fluid, and in the middle we have the ovum. Now coming to the structure, it is surrounded by the coronaradiata, and inside that we have the zona pellucida, which is the most protective membrane, and inside that we have the cytoplasm, the nucleus and the nucleolus. Cumulus ophorus is the layer of granulosa cell which is just present between the oocyte and the Graafian follicle. Another endocrinology theory that we have to remember is about the two-cell, two-gonadotropin theory. What does that mean? We have two gonadotropins, the FSH and the LH, and we have two cells which are your theca cells and the granulosa cells. The FSH acts on the granulosa cells, and remember the precursor for all this is cholesterol. So FSH acts on the granulosa cell and LH acts on the theca cells. The granulosa cell is the cell which is going to produce estradiol, whereas theca cell produces pregnenolone, DHEAS and androstenedione, which goes into the granulosa cell, where finally it gets converted into estradiol. Coming to penetration of the sperms. Now we see that though there are hundreds of sperms which enter, it is only one single sperm which is going to pierce the zona pellucida and make the ovum fertilized. So what are the layers it is going to penetrate? The first reaction is going to be between the acrosome. The acrosome reaches the corona radiata. From there it reaches the zona pellucida, where the acrosomal reaction takes place. The zona pellucida gets dissolved and the nucleus of the head, the nucleus of the sperm enters and leads to fertilization. Okay, so it's the corona radiata, that being the externalmost, followed by the zona pellucida, the plasma membrane, and finally enters into the oocyte cytoplasm. In a nutshell, about the menstrual cycle, which again is considered as an important topic for exams, we have the ovarian cycle and a little bit about the ovarian hormones, and we have the uterine cycle. If you take the ovarian cycle, it is basically the influence of FSH which is going to be present in the first half of the cycle until just before ovulation, where we find there's an LH surge which leads to ovulation. The second half is we'd have the LH and the FSH being in very low amounts. So the main hormones, if you take the anterior pituitary hormone, FSH is the hormone of the first half, LH just being around mid-cycle, and in the second half of the cycle both the hormones are present in very low levels. The ovarian hormones, we find estradiol predominates in the first half of the cycle up to ovulation, and the second half, that is the luteal phase or the secretory phase, is mainly by the progesterone hormone. Coming to uterine cycle, just after menstruation, which actually corresponds to the follicular phase, we find the endometrium is growing in phase, which is the proliferative phase, and next we have the luteal phase, which corresponds to the action of progesterone. So secretion of all the hormones takes place and spiraling of the arterioles is noted down. So this completes a little bit about the reproductive system. Going on ahead is about the various other disorders like the changes in the respiratory system, cardiovascular system, renal system, which are considered important. Coming to a typical exam-based question, which says that which of the following increases during pregnancy. So this question is basically revolving around the spirometry and the changes. So knowing about the spirometric definitions is very important. We have various definitions like the tidal volume, which is basically the amount of air that we inspire and expire during a normal breath, the inspiratory reserve volume, the expiratory reserve volume. This is basically the maximum volume of air that can be forcefully inhaled after a normal inspiration or expelled after a normal expiration. Coming to residual volume, that is the amount of air that cannot be exhaled from the lungs, or even after a forceful breath, what is the amount of air that stays back? That is called as residual volume. The vital capacity is the maximum volume of air that can be expelled out from the lungs after a maximum inhalation. Inspiratory capacity is after a normal expiration, what is the amount of air that the lungs are able to hold? That is your inspiratory reserve and the tidal volume together. The functional residual capacity is after a normal quiet expiration, what is the amount of air that is remaining in the lungs? That is the expiratory reserve volume and the residual volume. Coming to the total lung volume, it is the addition of inspiratory reserve volume, the tidal volume, the expiratory reserve volume and the residual volume. Knowing these definitions is definitely considered important from an view. And this is the spirometry graph, and this graph is going to depict us the various lung volumes. If you see, it starts from the inspiratory reserve volume and lower down we have the expiration, and the total lung capacity is a combination of all the volumes. A little about the changes in pregnancy. We do find that the physiological changes in pregnancy occur. So what are they? We find that the vital capacity is unchanged. The tidal volume increases by 40%. The total lung capacity reduces by 5%, and the functional residual capacity is reducing by 20%. So coming back to the question, it was the tidal volume. So the tidal volume increases by approximately 50%. The vital capacity is unchanged. Decrease in carbon dioxide affinity of hemoglobin due to oxygenation. What is this effect called as? So basis of gas exchange and the various effects. So the two important effects that we have to know about is the Bohr effect and the Haldane effect. Now what is Bohr effect? It is basically the changes that we see in the peripheries, and Haldane effect is the one that is noticed in the lungs. In lungs we see that there is a lot of oxygen, so the partial pressure of oxygen is high. Okay, because of this the carbon dioxide is going to bind less with hemoglobin. This is called as the Haldane effect. Whereas if you take the periphery tissues, we find in the peripheries the partial pressure of carbon dioxide being high. So this leads to less binding of oxygen to the hemoglobin. This is called as Bohr effect. Another important concept to remember is about the oxygen dissociation curve. Now, oxygen dissociation curve is basically giving us a representation of the partial pressure of oxygen with the percentage of hemoglobin saturation with oxygen. And we have to see the changes that causes the left side shift and the right side shift of this curve. Left side shift is seen, it is basically means that there is increased oxygen affinity, so there is less oxygen that goes to the tissue. So this is seen when the pH is quite high, that is more basic, the temperature is low amount of 2-3 BPG, and there is different hemoglobin apart from the adult, like the fetal hemoglobin, methemoglobin or carboxyhemoglobin. Whereas when we see the curve is shifting to the left, it means there is a reduced oxygen affinity, so more oxygen get delivered to the tissue. This is seen in more acidotic conditions where the pH reduces and there's an increase in carbon dioxide. Temperature is high amount of 2-3 BPG, and there is low oxygen affinity of the hemoglobin. Coming to another important concept is about the cardiac cycle. The cardiac cycle, we have to know about the correspondence with the ECG. We have the P wave, which represents the atrial depolarization, the QRS complex, which actually is the ventricular depolarization, and T wave, which is the ventricular repolarization. So the questions can be based on the changes in the ECG. Say for example, the T wave in ECG represents what? or they can ask regarding the ECG changes in normal pregnancy. So as I told, these are the changes and the correspondence to the ECG. And what are the most prominent ECG changes in pregnancy? There is a left shift of the heart axis. There's a change in the Q wave in lead 2 and 3. There can be small T wave abnormalities, a shortened PQ and a QT interval. And this ECG changes in various metabolic disorders is also considered important. In hypokalemia, we have flat or inverted T wave with ST depression, whereas in hyperkalemia, we have tall peaked T waves. These are characteristics of the potassium disorders. Whereas in hypocalcemia, we have a prolonged ST segment and a prolonged QT interval, whereas in hypercalcemia, we have a shortened ST segment. Coming to magnesium disorders, in hypomagnesemia, we have ST depression with a tall T wave, whereas in hypermagnesemia, we have a prolonged PR interval and QRS widening. Coming to some physiological changes that we see in the cardiovascular system, we see that the cardiac output increases by about 40 to 50%, the stroke volume increases by 30%, the heart rate by 15 to 25%, and the intravascular volume by 45%. When you look at the systemic vascular resistance, there's a reduction or drop by 20%. So is also the diastolic BP, which reduces by 20%. The coagulation factors, the factors which decrease are the free protein S, and there is no change seen in antithrombin 3, factor 2, 5, 9 and C, whereas the other factors increase in pregnancy. So the physiological anemia is caused because the blood volume is going to increase by 30 to 50%, whereas the plasma, it is mainly the plasma concentrate which is going to increase and not the RBC, and this is the reason of physiological anemia. Coming to about the fetal circulation, we need to know a little bit about what are the different fetal circulations and what happens after birth. This is a representation of the fetal circulation, and we know there are some unique connections that are seen in the fetal circulation. So what are they? To start with, we have the umbilical artery and the umbilical vein in the umbilical cord, and the umbilical vein is going to carry the oxygenated blood to the baby. Now this umbilical vein, when it enters the liver, we have the first connection of the ductus venosus, which is going to bypass the hepatic circulation and send all the blood into the inferior vena cava. So this oxygenated blood, which reaches the right atrium via the inferior vena cava, gets shunted into the left atrium, the majority of it, because of the foramen ovale, which is a connection between the right and the left atrium. There's a minimal amount of blood which reaches from the right atrium to the right ventricle and into the pulmonary circulation. The third connection is the ductus arteriosus, which is a connection between the pulmonary trunk and the aorta, and that is again for the differential transmission of blood or the oxygenated blood to the systemic part. And why is this important? Because we see in the fetus, the lungs or the pulmonary circulation is not very active and it is not functional. So we need all the oxygenated blood that is reaching the fetus to go to all the parts of the baby, especially to the peripheries. So what happens to this after birth? After birth, because of the changes in the pressure, and we know the pulmonary circulation is going to become active, all these close. The foramen ovale becomes the membranous ovale, the ductus arteriosus becomes the ligamentum arteriosus, and the ductus venosus becomes the ligamentum venosus. So these are the changes at birth. As soon as the cord is being clamped and the placental circulation goes, there is going to be the stimulus for the respiration. So there's a rise in the partial pressure of oxygen, the ductus arteriosus closes, the foramen ovale closes, and the neonatal circulation ceases, and we are going to have the fetal circulation ceases, and we have the neonatal circulation that is coming up. So going ahead to discuss about the renal changes in pregnancy, we have a question, a sample question, which says, in the kidney, the maximum glucose reabsorption takes place when? So these kind of very common. So they can also ask about any other ions, like say for example here we are being tested on the bicarbonate ions. So the answer is proximal convoluted tubule. So this is a representation of the various parts of the nephron and the reabsorption. As we see, the maximum reabsorption takes place in the proximal convoluted tubule, and this stands true for glucose, amino acids, proteins, vitamins, lactate, urea, uric acid, most of them. Whereas water reabsorption is maximum in the loop of Henle, and most of the filtration takes place in the distal convoluted tubule and in the collecting ducts. Another important concept about the renal physiology is about the secretion of renin and the renin-angiotensin system. So renin is basically secreted from the juxtaglomerular apparatus, which is present near the Bowman's capsule. So what are the stimuli for this renin secretion? Whenever there's a fall in BP or low ECV volume, or there's a low plasma sodium, these cells, the JG apparatus, gets stimulated, which leads to secretion of renin. The function of renin is to convert angiotensinogen, which is present in the plasma, into angiotensin 1. This angiotensin 1 will be acted upon by the enzyme called as angiotensin converting enzyme, which is secreted by the lungs, converting angiotensin 1 to angiotensin 2. The angiotensin 2, what are the main actions of it? It is going to regulate the glomerular filtration rate, it's going to increase the blood pressure, the water intake, and the ADH secretion too. The angiotensin 2 will get converted into angiotensin 3 and 4 by the enzyme angiotensinases. Now, what is the function of angiotensin 3? It is going to increase the aldosterone secretion and causes vasoconstriction. Now, this plays a major role because whenever there is changes in the ECF or the blood pressure, it is the renin-angiotensin system that comes into action. Coming to a little bit about twinning. Now, twinning, we have to know the stages of twinning and also the days of twinning. Okay. Now, coming to the stages is the morula. The morula, that the day 1 or 3, if the cleavage takes place, we have a dichorionic, diamniotic twin. If it is the stage of blastocyst, where the cleavage takes place between day 4 to day 8, we have a monochorionic but a diamniotic twin. If it is an implanted blastocyst that's going to cleave, that is around day 8 to 13, we have monochorionic and monoamniotic twins. And if the cleavage takes place between day 13 to 15, we are left with conjoined twins. So the respective representation in an ultrasound is the lambda sign and the T sign. A T sign is seen, it is a very thin sign, so there is no placental tissue that is present in between. Whereas in a lambda sign, we do have the placental tissue, so it is quite thickly appreciated in an ultrasound. So these are some very important concepts that are needed for the physiology module and for the exam preparation. Hope it was useful. Thank you.